my talk is basically about some of the other clinical possibilities of prostate micro-ultrasound and what we learned. The previous speakers have clearly outlined the challenges with conventional truss, with poor sensitivity. Multiparametric MRI is good, but it's not real time. It does not pick up all significant lesions. It picks up most of them, particularly multifocal disease. And there is plenty of descriptions about the poor prediction of lesion size. Micro-ultrasound is real time and appears to be very sensitive to diagnosing prostate cancer. So what we did is we have done 600 or so template mapping biopsies. Dr. Stone's going to talk about those tomorrow. And Dr. LaRosas, who's sitting in the back of the room here, in the middle of the room, is our pathologist with Priya Warahara, who worked very hard when we give them 150 biopsies to look at, and then 3D put those together. So what we wanted to do is see how the micro-ultrasound performed in our mapping biopsy population. So this is an example of a guy that had a Gleason 336 and 2 of 12 cores, a 437 and 3 of 12. I think he'd be a great candidate for radiation or surgery, but he wanted to get the male lumpectomy or see, is it possible that I could just have my cancer treated, doc, and not my whole prostate? So he had 82 biopsies, and this is a 3D reconstruction that Paul Arunga put together. And you can see his tumor is located primarily in the lower part of his prostate, but it is multifocal. And lo and behold, and we see this all the time, he has a Gleason 8 cancer. So we did prior to this procedure, we did the micro-ultrasound, and I have the real time right here to show you. And basically what we're going to do is the lesions are up here. We're going to put them with a red dye on it, and then you can see where it is right here once we move it. So this gives you, Dr. Klotz already outlined, and Dr. Shore, some of the characteristics that you see of tissue when you do the micro-ultrasound. So, how did we do? The micro-ultrasound does not give you good transverse imagery. It's coronal. There's ways to correct for that and look at it. But as you can see right here, and the Gleason 8 is in the green, it nailed it on both sides. There's the Gleason 8. And there's the 7, and it did pick up some of the 6s, and transferring out to the axial scans, you can see it here. Another case that we did is here. This is a guy that had a 336 and 2 of 12 cores. We know from our experience 30 to 40% of these people, when you do mapping biopsies, you're going to be upgraded. And he was one of those, and 102 biopsies that were done, he did have a 437 and a 336, and this is the distribution. Here's the 7 very close to the capsule right here on the patient's right. So we did the micro-ultrasound before we did the mapping biopsies, and the folks at ExactView, Dr. Woodlinger and his group, were blinded to the results of the mapping biopsies. And again, you can see here that it very nicely identified the lesions that were present. And here's the transverse being flipped over into the axial to show where it was. So whole mount data, we were not the only one. Dr. Woodlinger from Toronto has done a nice job of looking at doing this prior to radical prostatectomies. And they nailed 24 of 25 high-grade cancers, found 86% of the grade 2, group 2 lesions. Other publications, this is the one that everybody's been interested in, the PRECISION trial. And basically, the PRECISION trial published in the England Journal of Medicine suggests that a negative MRI can avoid a biopsy. And recent work suggests that the micro-ultrasound has comparable sensitivity to the MRI, so one might be able to do deductive logic and say, should we be using micro-ultrasound to avoid biopsies as well, and what additional data are required, and I think we're getting there to get that. Other clinical possibilities: active surveillance, identifying better patients, having better compliance, focal therapy. We've been doing this for over a decade, and it's amazing the interest in focal therapy right now. I call it targeted focal therapy if you do it right and know where the lesions are. Dr. Davis and I debated each other at the South Central section on focal therapy. I won. He used his showmanship and all his photography and images to try to prove I was wrong. But the funny thing was, in Urology Times, it was in Urology Times, there was a two-page thing where Davis is supporting focal therapy. So we know that Texans lie a lot anyway, particularly those at MD Anderson. So at any rate, focal therapy is something that's out there and something that can be used. And the nice thing about this, and we're working on, Priya Warahara, myself, others are working on ways to ablate tissue right away. So if you actually can see it, we can put Priya's optical biopsy needle in there and say, hey, that's cancer, and we put in our electrodes, turn on our AC current. We've got a one-stop shopping getting rid of prostate cancer. So it's pretty interesting. This isn't people are doing lasers. Here's a laser fiber. Here's an example of ablated tissue with lasers. Now, one of the other things of interest is cryotherapy. And we've now done 3 cases where we've done the micro-ultrasound before cryotherapy and actually during it. And this is one we just did last week. And the week before actually, and the guy had negative MRI. It was a salvage cryo. Lo and behold, look at this. This guy's got cancer extending through the capsule right here to the rectal wall and also near the seminal vessels, which was not seen nor known ahead of time. This was his original ultrasound. Actually, if you go back and look at it, when we did the cryo, you can see it in retrospect. And this is it right here. So we did the cryo, and here's the cryo and the ice ball. And you can see very nicely the delineation you can see here, but here's the shrinking of the ice ball. And so the exact ultrasound gives you beautiful views, much better than we're seeing with our standard cryo of the anatomy down here, which is nice. So we can play chicken with the rectum a little bit more, I think, than we have in the past with our standard ultrasound. And then that lesion that I told you about, we try to nail it with the cryo, but we didn't. I don't think we got the whole thing. So in conclusion, 29 megahertz ultrasound is a promising new modality. We have 3 people that have presented that right now. We think that it has similar sensitivity to multiparametric MRI. I agree with Dr. Klotz that there's a learning curve that exists that's significant. And the data, this is disruptive technologies, and there's no question. I really predict that urologists are going to embrace this. Why? Because one, I know we have radiologists here, Dr. Bush, who's done more MRIs than anybody in the world, and other people here, and Ryder in the UCLA group. But you know what? I think that this is in the hands of urologists. There's a place for MRI, but you get instantaneous gratification and outcomes here. Thank you.